With that, I'd like to really transition to our first speaker, David Covington. So David, he's going to talk to us today about this issue of suicide, and particularly a real challenge to the field about zero suicide in healthcare. And this is paradigm shifting for us, because I think we've often in our field had the sense that, we do everything we can do to prevent suicide, but it's going to happen. And this is about really taking a zero tolerance approach to the suicide issue, and I think it's a great challenge for us. So David is CEO and president of Crisis Access, LLC. He leads the entrepreneurial joint venture of Behavioral Health Link, Protocol Services, and Recovery Innovations. And these sponsoring companies focus on what is strong, not what is wrong, and have niche expertise and passion for crisis. Their teams have touched millions of individuals and families via living room and restart programs, telephone chat, and mobile outreach. Previously, he was Vice President of Clinical and Program Outcomes for Magellan. And David, you're a leader in this field, and we're so grateful to have you here today to talk to us about zero suicide, and anxious to see what that will hold for us.
Thank you so much, Tom. And good morning to all of you. Mobilize, innovate, and thrive. Wow. That's what I've really felt like. We've been in a partnership with Centerstone over the course of the last several years now in this space of what is being known now internationally as zero suicide in healthcare. And leaders like Bob and David and Barry and this team of Becky and Tom and Jennifer Lockman and others, it's really pretty inspiring and motivating. And that's the reason we're here today, to begin to think about suicide in a different way. To look at this as if we haven't seen it before. Now that's extraordinarily hard when you've seen it in the way that you've seen it for as many years as you've seen it. But what is this? Because you've seen it a million times. Stadium seats, a building. This is the Golden Gate Bridge. And for those of you who maybe saw the cable up in the fog, I'm standing on the bridge. We're not looking at the bridge. We're not looking down at the bridge, which is really the way it's normally pictured in hundreds and hundreds of thousands of different views of this iconic structure. I'm looking up. And that's what we're going to do with suicide today. We're going to use this bridge as a metaphor for the way we in community behavioral health have saved, and we've saved many lives related to suicide. But let's think about it way differently, and this structure is going to come back up as we talk. Now, we all took a certain approach to suicide in our agencies over the last decades. It's time to change that approach because of things we've learned over the last 10 years. We've learned from a survivor community, individuals who are peers and leaders who are voicing their experience in ways we've never heard and understood it before. Science is beginning to research and drill down on this and provide tools and evidence-based practices in a way that we did not have 10 years ago. And so it's allowed us to tackle tough questions. And thank you for being here, for jumping into a very, this work is hard at times. It takes courage, it takes tenacity. So let's just jump right into it and start with a difficult question. An individual who died by hanging with their hands bound behind their back and their feet tied together, that was really a murder, not a suicide. How many would have agreed with that? At least in the past, you would have looked at that kind of situation and said that had to be a murder. A family in California grieving the death of their daughter thinks the same thing. This was actually a big story in the media about a year and a half ago. And their daughter died in that way. And for those of us who haven't been through depression and suicidality that's so debilitating, the only parallel is physical pain. It's hard for us to take the normal ebbs and flows of life and to relate to what it is when a person is in that darkness. Sadly, this is actually not an uncommon thing that happens for someone who kills themselves. Now, why would someone bind their own feet and then their hands behind their back before attempting to end their life by hanging. Why? They don't want to change their mind. Now, that doesn't fit with what I was taught for the first 20 years. It doesn't fit with what psychiatrists are taught, and it doesn't fit with what emergency room medical attending doctors are taught. And that is, those who are ambivalent aren't really serious. They're seeking attention. They're gesturing. They're manipulative. It's a cry for help. Let me tell you, if you put your neck in a noose, that is a very serious, dangerous situation. And yet, sadly, this is exactly what does occur. I myself was struggling with this, and for those of you who know Dr. Thomas Joyner, who's one of the field's preeminent leaders, he said, sadly, this occurs. Now, despite that ambivalence, we in the behavioral health field have been taken to task for our approach, and it's not just us, not just public sector, not just behavioral health, not just providers. The entire field was taken to task in an article called The Forgotten Patient in Forbes magazine in 2010. They also set their sights on research, pharmacology, administration, policymakers, health plans, etc. But what they said was, if someone has addiction or depression or anxiety or a child with ADHD, they get love and attention and best practice and research, and that light of care shines on them. Now, they didn't say that the person with suicidality gets pushed out. They said they get pushed to the periphery. I grew up in community behavioral health. I'm a counselor who worked in a not-for-profit in rural Georgia for many years, eventually worked into administration and management of organizations, and then was responsible for many organizations at the same time. What I think we've done is we've all had suicide care under our umbrella, but it was a secondary business for us. What is the first business for the Golden Gate Bridge? Transportation. Hundreds and hundreds and hundreds of millions of transports into that northern edge of the city. Secondary business. No, definitely not. But close. We're getting there. Think second. What's their second most important thing? Tourism. 5,000 people a day walking out on that bridge. And then, what's your name? Harrison. And then they would say, it's on the periphery. And hey, let's not say they don't save lives. They do. They probably save 2 lives for every 1 person who dies there. They have a trained security force who knows crisis stabilization. They know quick intervention. They can de-escalate, negotiate. They'll wrestle people off of the apron of that bridge. So this has been the Golden Gate Bridge has been a very powerful tool for many things, and yet it hasn't been a very safe place. Community behavioral health, our settings, have led millions and millions of people to better lives in community. And we've saved many lives, even those at risk of suicide, and yet it's not been a very safe place for some. I think all of us were surprised when Samhsa kind of happened upon the data a few years ago that 9 million Americans a year are seriously contemplating suicide. That surprised those of us who had even been in the field for a time. Now, the rates differ dramatically from state to state. I live here, and the rates here are significantly higher than rates in Tennessee and Indiana, Illinois, some of these states here. In the Northeast, we have some states where the rate is half of that. So it varies dramatically depending on where you live in the country. It varies dramatically depending on your age and your race. I'm not. Maybe some of you in the room are becoming older white males. Is anybody becoming an older white male? I'm not. But if I was, my risk would be going up over the course of my life. An Alaskan, Indian, American, Native, a male, the opposite. Their rate is coming down after their 20s. African American females, yes, they do die by suicide, but at rates phenomenally lower than the others. There are things to learn from that. I'm not going to go there today, but again, we're talking about how to save a life. So what have we learned over the past decade? And what are we still learning? To me, this is the fundamental question. Your answer to this dictates what you go back and do with your organization to make it a zero suicide and healthcare initiative like Centerstone America is doing, like the Institute for Family Health is doing in New York, 30 federally qualified health center sites across the state, like what a hospital healthcare system in Christchurch, New Zealand is doing right now, and a behavioral health full spectrum service continuum in the Netherlands is doing. Depends on your answer to this question. Everyone believes suicide can be prevented, but with some caveats. So, A, never in those truly intent on suicide. That's sort of like saying suicide can be prevented, except when it can't, which is what most of us have believed. I believe that. I don't like the fact that I believe that, but I cannot deny that that's what most of us believed. Now, the field is moving. The Department of Defense has an initiative on suicide. I'm watching them go from A, B. I think they're on C now. It's picking up pace sometimes, but only in advance of acute risk. Always, but only in advance of acute risk. And what those of us who are in the Zero Suicide Initiative believe, always, even up to the last moment. A person who would bind their own hands and feet in order to get past. Why are we here today? Well, for many reasons, right? But one reason we're here today is because human beings have an internal security system. Our brains and our bodies don't cooperate with the desire to end the pain that we're going through. They will fight back till the very end. If you are partnering with someone to try to help save their life, their body will be a partner. If you cut it, it will clot. If you try to deprive it of oxygen, it will render itself unconscious. But the mind also does not cooperate. It works to stay alive. Now, we should have known that many years ago, and we missed the signs, we missed the research. In 1975, the Golden Gate Bridge was nearing its 500th death. And shockingly, a local radio station offered a prize package for the winner. That was the view in the local community. There was a lot of debate about putting up a barrier that would stop deaths on that bridge. And a barrier was not put up for 3 reasons. Most important reason, well, yes, but get closer. Aesthetics. The houses along that road that look at the Golden Gate Bridge are worth how much times their normal value? 10? A $2 million house is $20 million because you can look at that bridge, which brings tourism because it's an iconic, it's an amazing fit. It's just amazing. We don't want to change the aesthetics, and changing the aesthetics would cost money, reason number 2. But the real reason we wouldn't change the aesthetics and spend the money to do that is because a person who went to the Golden Gate Bridge and found a barrier that preventing them from ending their life would do what? Go somewhere else and do the same thing or something different if required. Because the person intent on suicide can't be stopped, is what we've told ourselves again and again. Now, Dr. David Rosen, a psychiatrist in San Francisco, said, I can't be content with that. I want to try to tackle that. He went and interviewed 7 of the 10 known survivors who had jumped from that bridge and died, who had not died. Now, jumping from the Golden Gate Bridge is one of the most lethal things that a person can do, even above using a firearm, as hard as that is to believe. How many of you have been to the bridge? The rail is about here. It's 3.5 feet. And from that bridge, looking out, you can see Angel Island and Alcatraz and the jewel of the city. It's an amazing sight. But anything that's dropped from that bridge, 280 feet up, takes 4 seconds to hit the surface. increases to a speed of 75 miles per hour, and hits with the equivalent of concrete before being driven deep into the water. About 1 to 2% of individuals who have done that have survived, most of whom have had pretty significant injuries, but not all. But there were 7 individuals that David Rosen talked to, and he didn't know. He actually thought, did they see a white light? Did their lives pass before their eyes? Were they even conscious? We didn't know. I'm going to skip what he found for a moment. It didn't change anything at that time. 3 years later, Dr. Richard Seiden, another San Francisco psychiatrist, said, I'll try a different tact. I'll go at it from this angle. What about individuals who were taken off the apron of the bridge? That rail, on the other side of that rail, is a ledge. And he went back and found the records for 515 people on that apron, just inches away from near certain death, who were talked over or wrestled over and then taken to some kind of crisis assessment. Now, if it was true that individuals intent on dying by suicide can't be stopped, we should have found a large number of them who went on to die by suicide. The average age, the average length of time between their being touched at the bridge and his researching their case was 25 years. This bridge has been around 80 years now. What percentage of them went on to die by suicide? They went someplace else. They did something different. What we had believed that had kept us from changing the aesthetics or spending the money would suggest 50, 60, 80, 100%. In fact, 6% had gone on to die by suicide. Now, that's a phenomenally high figure. And yet, it struck hard into the heart of what we had believed about intent. 94%, despite being that close to almost certain death, had gone on to survive. William Styron, how many of you have read Darkness Visible? A few. William Styron, one of America's top literary talents, said, I don't know how to communicate to you what is akin to physical anguish of what it's like to experience a suicidal depression. Now, let's flash forward all the way to 2003. Research that suggested we should do something different and think about this differently had been out there in San Francisco for decades now. Basically a writer for the New Yorker magazine named Tad Friend wrote this article, Jumpers. And he went back and unearthed the Seiden and Rosen research, and it sent shockwaves, not through the suicide or behavioral health communities per se, but it was a national phenomenon in terms of the interest in this, that was read by a documentarian named Eric Steele. Eric went to the Golden Gate Bridge and said, I'd like to videotape your bridge for a year. I'm going to set up in the park with my camera and videotape it because I'm interested in the architecture. He might have just fibbed just a wee little bit. You can see this young woman who's standing on the apron across the rail. He caught on camera 22 of the 24 deaths that occurred during that year. He thinks he stopped a couple of deaths by alerting their security to intervene. It's still a very controversial film in the suicide prevention field. But within months, the Golden Gate Bridge Authority voted 15-1 to do what it hadn't done in the first 75 years. And that is to put a plastic-coated steel safety net under the entirety of the bridge. They decided that it's not third, it's not second to spend that kind of money and make that kind of effort. That's primary. That's central focus. Moving them into the light, really beginning to bring the effort to make a change. Now, I think at the heart of why we believe people intent on suicide can't be stopped is we see suicidality, the intrapsychic experience, as being two different things. There's a group who talks about suicide and a group who dies by suicide. The group, and I get why people think that, the group who don't die but make attempts looks really different. It's predominantly female. It's predominantly younger. Includes a lot of LGBT youth. We talk about that group. When we talk about those who die, we're talking predominantly about older, we're talking about white, and we're talking about male. And so we think that's two different experiences. A group intent can't be stopped, a group that's ambivalent, seeks attention, squanders our resources. The reality is, that young woman there, standing on the apron of the bridge, was wrestled off the bridge. Have any of you seen the Bridge documentary? Did you yell at the photographer when he was... There's a photographer that's taking pictures of her. He was taking pictures of Alcatraz, I think, when he started seeing this young woman climb over the rail, and he started snapping pictures of her as she went out and stood. You can see her foot's over the edge. He finally put down the camera, walked over and started to talk to her. No response. Grabbed her by the jacket and wrestled her up across the bridge and sat on her until the security got there. This woman is, I think she did in fact make a return to the bridge, but today she is, what I've been told is she's a social worker and she has 2 children that all occurred post this event. Survivors survive. Diagnosis is not destiny. So, what are we doing as organizations to provide supports that would help individuals who are struggling with what we now understand is very different? And the risk for those that we're working with is manifold greater. This isn't an area that's been attended to. Nationally, when we talk about high risk, the National Action Alliance immediately put task forces to high-risk groups when it was formed 4 years ago. What were the groups that it attended to? Veterans and active duty, and they are at risk 2 or 3, maybe 4 times that of the general population. LGBT youth, again, make a lot more attempts than adolescents who are not. Alaskan Natives, American Indians, yes, they're a higher risk group. But if we put the risk of those 3 groups together, it doesn't equal the risk of those with serious mental illness, which we believe is somewhere between 12 and 15 times higher than the general population, especially for those who have a first break during that first year after diagnosis. Someone who's ultimately going to be determined that they have schizophrenia or bipolar disorder, their risk is highest during that first year. Those are the individuals that we are working with. Richard McKeon is the bureau chief for Samhsa's suicide prevention efforts. He made this statement in a task force that Mike Hogan and I were facilitating on this topic. Over the decades, individual mental health clinicians have made heroic efforts to save lives, but systems of care have done very little. When I heard that, it kind of burned me a little bit. I'm like, well, I'm responsible for systems of care. I don't like the sound of that because we have done things. And yet, have we taken the systematic efforts that put this as central focus? Whereas there's no question, it's not secondary, it's not tertiary. It's part of that bright light. Mike Hogan, suicide represents our worst case failure in mental health care. We must work to make it a never event. Now, we have taken some flack for even just the phraseology, zero suicide in health care. It was actually inspired by a number of things, but this is one of the things. We talked about getting older and being white. I found myself on this mailing list, which I wasn't really thrilled about, but prostate cancer kills older white males. And yet their campaign is called Zero Cancer, and zerocancer.org is their website. Really not controversial at all, despite the fact it kills about the same number of Americans every year. Why is this one not controversial? It happens to you. In essence, I had someone say this to me, no one chooses cancer. I'm actually going to give a TED talk at this conference and tackle the question of whether choice is the right metaphor when it comes to suicide. We believe that prostate cancer, identified early, is treatable. And we have not believed that about suicide, despite the fact initiatives have taken it on as systems and driven down their rates. The Air Force did it. Why did the Air Force do it? Because top leadership was seeing the data come across their desks, talking about increasing rates, and those same top leaders had friends of theirs in the top military who were dying by suicide. That combination together put a major focus on this in the 90s that drove down the rates pretty significantly. The rate started to go back up, and there's been some controversy as whether that meant the Air Force initiative didn't work. What happened in the late 90s, early 2000s? What happened to the Air Force? We went to war. They began to shift their focus other ways. When they put the focus back on, the rates have come back down. The Henry Ford Health System has also done this. The Henry Ford Health System determined that they were going to take a zero-defect, robust performance improvement approach with suicide like they would tackle diabetes or other quality improvement initiatives, inpatient falls, medication errors, doing the wrong surgery on the wrong person, which sometimes happens, or the wrong surgery on the right person but on the wrong side of their body, the right arm instead of the left arm. Those initiatives, we believe that we can reduce. If you go to the hospital today, your chances of acquiring an infection, they're still there, but they're reduced significantly from what they used to be because of robust performance improvement, training all staff, providing the protocols, using your processes, your electronic health medical record, creating a clinical pathway, as Becky likes to call it. So a zero suicide initiative is around moving away from just tools that clinicians electively acquire or that maybe are provided to them, to robust systems of care where the enterprise takes this on as a central focus and it's woven into everyone's job. Now we have a website, zerosuicide.com, where we are beginning to bring these innovative partners together and all of the work that's being done is shared there. We have 7 essential elements that we believe are behind making a center suicide safer. And they have to do with training the workforce, creating systematic tools for screening and assessment, and clinical pathways that support individuals. Becky just provided with an international collaborative now the protocols that Centerstone has developed for lethal means reduction and restriction, for working with individuals to ensure that when they are at most risk, we have raised that rail to the highest extent we can in working with the family, the community, the clinician, the case manager, the psychiatrist, the care, wrapping around that individual. We don't believe any longer that there's an intrapsychic difference between that 17-year-old female who comes into the ER and takes a few pills and the active duty, trained paramilitary. If they both have severe anguish internally and they're trying to end their pain, they're going to go about that in different ways. One's trained to do that, one isn't, and has to begin to climb their way up a wall that's pretty high. We want to raise that wall for all. And in fact, in Israel, they begin, for everyone who goes to the military, when you went home over the weekend, you had to leave your firearms. You couldn't take them home with you. They changed that protocol. Guess what happened to suicide deaths over the course of the weekend? These are a lot simpler than we would like to think. Now, in terms of the workforces that we're all engaged with, going back to this comment that Richard McKeon made about systems of care haven't done enough. What about those clinicians? Are they trained? Are they equipped to engage those at risk of suicide? We've now assessed about 35,000 behavioral health professionals. I'm going to just skip ahead. They look like this. This is Teros. Some of you know Teros. They're a community behavioral health provider in Phoenix. But that national survey looks about like this. Case managers, clinicians, physicians, nurses, etc. When we began this initiative, about 1 in 10 of those staff had electively taken suicide care training because they had an interest. They had a family member who had died. They were engaged in mobile crisis or worked on a crisis call line. So they had taken on that training on their own. Today, Teros has trained 80+% of their staff, and they're working to get that to 100. They've changed the culture of that organization where it's not on the periphery anymore. It's a central focus. One of their site managers came to me and said, I have to admit, our site used to be the hot potato, and we would actively work to get that responsibility to someone else when suicide came up. And today, when a receptionist has someone mention this at the front desk, they do the equivalent of throw their arms around the individual and say, we can help. Let's work together on this. It's not a phenomenal amount of work that has to be done to get here, but it does have to do with a focus, a mobilization, an innovation. And I think what will happen is not only the results with our individuals will change, but also the confidence and competence of your teams with the support of their organizations leads to a different type of retention and satisfaction with their work. I think if you can close this area, because typically staff feel really confident with doing most all the things that they do, but this one scares them, and it scares them badly. And if we can support them and encouraging them here, we believe the cascading effects of that are significant. Thank you so much. We look forward to continuing to engage on this topic together. And I think, Tom, we're going to transition into some discussion.
Thank you, David. I think it's so great to have you here this morning and to really hear your charge and your challenge to the industry. We're so grateful for that. It's been something that at Centerstone we've really embraced, and I'm going to ask in a moment, I'm going to ask Becky Stoll, who's led our systems efforts around zero suicide, to talk a little bit about that. But at a broader issue, as I think about this, we've had a history within Knowledge Network of adopting significant challenges to our field, whether it's been the use of clozapine and other ways that we can work together to improve practice. And one of the real challenges I'd like to throw out for this group, and we'll talk about this as we move into some of the work group discussion this afternoon, is this really something we want to take on and say, we want to work together, share our information. We've already really worked in the area of suicide before to partner. So I'd like to ask you to think about that, but for a moment, Becky, if you could just share for a moment about a little bit about the work that you've been up to with Centerstone and driving zero suicide in our environment.
Sure. Okay. So at Centerstone, we thought we were doing a decent enough job at preventing our patients and our clients from taking their lives. But once we had a connection to this initiative, which was probably 1.5 years, 2 years ago, it was really very eye-opening for us that we did not have a system, and I didn't hear David say it today, though I've heard him say it, or do you? Oh, I've heard him say it many, many times, is we had a system that suicide prevention and intervention was a bolt-on to our system. So if we had a client or a patient that was suicidal, therapy session would stop, the case management session would stop, and we would send them to that person down the hall, which really was my staff, who knew how to handle that. And so we really had a system in place that kind of just latched on to our overall system of care. And hearing David speak for the first time a couple of years ago, and looking at just some of these same scenarios and slides, we really realized we were not doing a good job of baking suicide prevention and intervention into our system. And hearing David say that for the first time, I love it. It's the best statement I've heard about this initiative, because your systems need to have it baked in. And we looked at it from a systems standpoint and said, what are all the things that we need to have in place? And that's a great look. It's a 35,000-foot view. But we, as a very large agency, had to look and go, that's wonderful from a 35,000-foot view. That's where you start. But you also, with clients, have to have about the 5,000-foot view. And so when you talk about means restrictions and assessing and intervening evidence-based practice. I mean, the list goes on and on and on. Rubber meeting the road, and does anybody have a policy on that? Has anybody modified their electronic health record to help the clinicians do that? We found it really wasn't there. And so it's been a real treat to get to work with some of the experts in the field around the Zero Suicide Toolkit that's up online. And agencies that are either primarily behavioral health or they're integrated care, or hopefully just even getting some of the medical profession to put things in the toolkit so that agencies and entities and behavioral health and integrated care companies that want to start this work aren't starting at square one like we did. And so if you get on zerosuicide.org, that's where the toolkit is, and it's built around these different modules that help agencies get started. And we've done a lot of that work. And I think our estimates, we have saved some lives if we look historically at some of our data. And we're continuing. I describe we call it a clinical pathway. And we said if we screen and assess folks and they are high risk, we're going to put them on this path to watch them and monitor them and give them the best care we can until they're no longer suicidal. And so I've described her as a fairly decent looking lady, and she's got on a nice pair of slacks and a top and a pair of shoes. We're so large, that's about as much as we can handle right now. But she needs some lipstick, and she needs a belt, she needs some earrings. We're going to bake those things onto her. Well, we won't bake her. We're going to add those things into our pathway to make it we have so many ideas about things that we're going to do to make her much more robust. And it's going to take us a couple of years to do that. So we really hope some of you guys have some interest in that too and can dress her up with us.
Well, I think it's, Tom, you were challenging the Knowledge Network. Is this something that they want to take on with you? And Becky's right. Some tools have come to us. We took the work of Henry Ford, some things we saw from the VA, some things we saw from the Air Force Initiative. We've started to pull those together. Centerstone has delivered ideas to this collaborative. The state of Kentucky shared with us an organizational assessment. We had created an individual workforce assessment. The state of Texas brought us the idea of suicide safer care systems and what might be a part of them. But we're still relatively early on in this initiative. We had the idea of this being a learning curve with early adopters putting into place what we've developed. It's not that baked yet. So I think the time for innovating this and creating this is now. You've got organizations literally around the world challenging and tackling this, but they're doing what Becky's doing. They're saying exactly how do I do it. So the time to innovate that and create that is happening right now.
One of the real challenges we've experienced as we've gone on this journey is a lot of it is uncharted. You can look to what other organizations are doing, but a lot of the tools that are out there, whether it's some of the training models or how do you really do as we said, it's a systems intervention, not just it's not a class that you go to and learn, here are the 3 steps to suicide prevention. It's how do you begin to re-engineer your entire system so that you're able to address this in a comprehensive manner. And that's, again, one of the areas that I think we focused on historically is how do you, through our implementation work, is how do you begin to transform systems in positive ways and make a difference. And that's again, why, as I've thought about this, it's something that really resonates. So I know there's a question back there. So.
As far as the question whether to support an effort to reduce and bring to the front suicidal ideation, I want to put my hand up and say, if you form a task force, I'd like to join.
Great.
It's easy not to talk about. It's the hardest thing to ask a patient about. And I want to share a story because we run an FQHC in Bronx. It has a step-down unit for 200 women that leave prison before they go out to single-room occupancy housing. It's a dormitory setting. And 2 years ago, there was, on an average, 8 suicides a year. And since we've implemented a very basic program that if somebody triggers suicide rarely or more on any of the screens that any of you use, they ask 3 simple questions. Is there a family history? Have you tried it? Do you have a plan? These didn't cost much money. The next year, 0 suicides in the same dormitory. So if everybody puts their heads together, this is an ugly question to start Sunday morning at 9 o'clock, great warm-up. And I'll put my hand up.
Good morning, and bless you for the work that you're doing. I have a question about what your strategies are in terms of the broader community. Most of the people who commit suicide in my community are not my clients. Half of them saw their primary care within the 30 days prior. More people die from automobile wrecks from suicide than automobile wrecks. And so I feel that my focus of attention for just my own clients is maybe too small for my community. So I was curious what your thoughts and initiatives have been with broader communities.
Well, let me speak for myself, and these guys may have a different approach at Centerstone, but I was responsible for about almost 100,000 people in the Phoenix, Arizona area that we delivered care to with about, 50 to 100 major community behavioral health provider agencies. And we got asked that question continuously. The way I thought about it is I'm the Golden Gate Bridge Authority's board of the chair of the board. I don't know what happens on the Bay Bridge, and I don't know what happens in the city, but I can tell you that my bridge was not a safe place, and I wanted to make my backyard safer. And that's what I found when I came to Phoenix. You talk about 8 suicides a year. We had many, many more than that. Well, over the course of my tenure at Magellan, over a 5-year period, we reduced the suicide rate dramatically, and yet we still had 200 plus deaths. It's shocking numbers. I think if you look at an individual community behavioral health agency, your numbers may be for them to be somewhere between 0 and 10 is probably most organizations. And yet what we're saying is this is one of the major things that is affecting your staff. If you assess your teams, and I encourage you to do that, and Becky, Tom, we can provide you the supports to do that survey, you'll find that if a person comes in with suicidality to talk to one of your social workers, clinicians, case managers, it's true all the way up to the psychiatrists. But at anyone below the psychiatrist, on the aggregate, you can basically flip a coin. And it's a heads that they'll at least agree to 3 questions. I have the training, I have the supports, and I have the skills to engage those at risk of suicide. So it's true that a lot of people die by suicide who are not under the behavioral health system, but it's actually not as many as we have thought. I used to think that was true to like the 80 to 95% level. The state of Kentucky recently did a survey crosswalking the deaths from their violent death reporting system to the behavioral health system. They found more than 30% had been served in specialty behavioral health. That's those that we have direct responsibility for. The problem with the national system is gatekeep and identify risk and refer them to a mental health counselor. When you've got a coin toss chance of even that person self-reporting that this doesn't cause them pain in their stomach, that difficult question. So what we're encouraging folks to do is let's get these systems right in our own backyards, and there will be cascading effects to those broader communities.
And I think what we've done, where's Jan? Oh, we're working on an application now for some work that we may do and looking just at that. And I think some of the hot points are ERs for clients that will never grace the door of a mental health system. So I think hitting ERs, pulling in primary care physician and pediatric practices where they may never grace the door of our mental health system so that we teach them to screen and assess. And screening is 2 questions for the most part. It's not very time consuming. So I think ERs, medical practices, whether that's for adults or kids, and I know in Tennessee they did a big campaign at gun shops. We like our guns, and I'm scared of them, but in the South we like those, and lots of places have them. And they did some real targeted educational stuff with gun gun shop owners, because we had some folks that would go in and rent a gun, and they had suicides actually in the gun ranges. So I think you're right. I mean, David's right, but you have to roll out and look at what's the next hot spot. And I think in this world, it's ERs and PCP and pediatric settings.
I'm going to take Tom's lead and be disruptive. I know it's surprising. Did Kevin Scalia say that? Yeah. If we as behavioral health are going to have the impact that we truly should have on the quality of life in our communities, if we were to take responsibility for the whole community, for training physicians, for calling for zero suicide throughout the community, we would accomplish a very important thing, which is we would establish ourselves as the authority in healthcare. We would drive customers to our services, and people would not die as often from suicide. I had an art professor. He was a sculptor, Jack Cartledge, at New College in Sarasota, Florida. And the students would be making their sculptures with putty, and he would be teaching them. And his typical thing was to take 20 pounds of clay and throw it on the board on top of the 2 pounds of clay that the students were working with and say, think bigger. And he'd mush whatever they were working on. Think bigger.
Yeah, I was just going to say, too, I think we forget how many touch points we have in the community. You know, I mean, think of all the school-based services we provide, these, forging newer relationships is part of it, but also just leveraging, as you think about baking that in, really have a conversation about what you're already doing that's not necessarily working with a client that's already engaged, but where we can screen and identify others that aren't.
60% of all primary care told the Medical Association they don't have a behavioral health referral.
What is your name, Miss Disruptor?
Mary Lydia Ruiz. And when I'm called Mary Lydia, I know I'm in trouble.
So one of the things, Mary, is striking for me that's interesting is 4 years ago, I was feeling like the redheaded stepchild, that we could not get traction in the broader healthcare environment, that we were almost a non-factor. And then a year later, I'm on an executive committee with the Secretary of the Army chairing it, and all of these branches of government around the room, with the big hitters from HHS there. And guess who was leading the room? The behavioral health. Pam Hyde was really the voice kind of championing, leading that table because of this issue of suicide. It's an interesting, if we take ownership here, there are some cascading impacts around leadership that I think you're hitting on for me.
Universal screening in schools.
Yeah. The only thing that...
On and on. You can own the world of this issue.
The only thing I'll say, Mary, is my belief is if you haven't tackled this before, there's some work to do in our organizations to create suicide safer, and that's a lot of work. So, but you're casting for me a bigger vision that's exciting. I love that metaphor of throwing 20 pounds of clay on 2. Wow, that's going to haunt me this whole conference. But
I mean, just thinking about it, the theme of the discussion today is really about preparing our organizations for value-based care and moving forward in this. And really the reason we wanted to talk about this topic, it's exactly to your comments, Mary. This is an opportunity for us. This is our sweet spot. This is something that we are really uniquely prepared to do, and value we're uniquely prepared to bring to the healthcare system. So if we don't seize that opportunity, we really have our Kodak moment. We only have ourselves to blame for not moving forward and grabbing that. Debbie?
Good morning. I'm Debbie Cagle with Vantage Behavioral Health. I'm one of the companies of Centerstone. Just to add on the numbers related to veterans, I think they're probably understated. We know that between 22 and 23 veterans and active duty commit suicide every day. In the last hour we've been sitting here. Somebody's probably killed themselves. But just to note, those 22 to 23 are based on death certificates, and not all states report. We have seen a a large number of veterans commit suicide in the United States. There's 23 million living veterans. Only 9 million of them have access to VA benefits, so the VA is not able to catch all of them. And there's an increasing number of suicides amongst people who have never been deployed and female active duty and veterans. So I would suggest that as we're working with our all of our service branches and the National Guard, that however we can help, again, like Mary, being a disruptor, it's a huge, huge travesty amongst people who have given so much to serve us and to help us have freedom.
Agreed. Did you have a comment?
No, actually, I was up there. Yeah. It was actually already said. I was just saying I was going to say our Kodak moment was this disruptive. It was pretty much exactly what Mary said. Is in terms of primary care, I think our opportunity really is now. Primary care physicians don't know what to do with suicidal patients. I think they want behavioral health. They don't know what to do when it comes with behavioral health oftentimes. And I think as individuals who are working with FQHCs, the same thing's really true as we're looking at integration. I was going to use the Kodak metaphor. It really already has been said. Our opportunity is now, and I think as you said, David, we have to internally know what we're doing. I think we really need to have a sense of how we're going in our own organizations. But if we're truly going to transform, we need to be able to reach out to other organizations in a way that shows that we know how to take care of those populations. So I think that in true form, we really have the ability to stop. And I think primary care physicians, as we know, they're the ones who are going to be seeing patients and they don't know what to do, and just by having ease of access to our services is by far the most important aspects.
April?
No, hi. You had mentioned when you talked about this initiative the fact that it was controversial, the zero suicide in healthcare. And for me, that doesn't compute. I mean, it's really it's a progressive, almost an activist movement to do the right thing, but it doesn't register for me for why that would be controversial.
The controversy has been around the language, and it's come primarily from suicide prevention leaders and medical leaders who've operated under the assumption that you cannot stop a person who's truly intent on ending their life. And let me say also, I've had a couple of family members come to me and say, wow, thanks a lot for heaping more grief on my already difficult ability to cope with this. And I've sat down and had some heart-to-hearts and real, conversations. I had one woman say to me, would you please at least just modify your presentation and say suicide isn't always preventable? And hey, this is not easy. When I think about the 1,500 plus people who've died at the Golden Gate Bridge, here's what I think they've all done. Tragically. I didn't go over this story because some of you have heard it before, but if you've seen the Bridge documentary, there's an interview with Kevin Hines, who jumped from that bridge and survived. And I didn't go back to Dr. David Rosen's study. What he found was those individuals, all 7, and Kevin, who was in the Bridge documentary, talked about they would do anything to end their pain when they were on that bridge. Anything. 1 second later, they're in the air, and time just slows down. It's the same thing that happens when any of us are in real distress. And they would instantly do anything to be back on that bridge. That's tragic looking back. But for me, it's also extraordinarily hopeful. I think all those 1,500 people, that's what they went through.
And I think from a provider perspective, we heard that too. And it was just education on our part to the staff it's a goal. And when
It's an
you
aspiration.
and when you talk to them about what else is appropriate, they get it. Even the ones that say, and we do have some clinicians that say, gosh, there's some folks there's nothing we can do about. Okay, if that's your belief, but if our goal is anything but 0, how is that appropriate? And they get that. So I say, okay, is it 2? Bob Vero, CEO of Centerstone, Suzanne Kozel, Indiana, is it 2? We're okay with 2? And they get that. And then they go, okay. And they usually come on board. So I think a lot of it's education and wording.
One other piece for that, Mary mentioned traffic deaths. Traffic deaths just recently came under suicide. And that's going to keep dropping and keep dropping and keep dropping. And eventually, I know it's hard to conceive of, but I think all of us are starting to realize Google's going to get the computer-driven thing down. We're going to drive that thing, to just almost never. It may be within our lifetimes.
There's some new standards coming out that relate to substance abuse, and why isn't this a HEDA standard?
Mike Hogan would I'm going to tell him you said that, Debbie. He's been talking really health plans is where we need to be having this conversation.
I know we're going to be talking about quality measurement a bit later on, and I want to go back to primary care. So there'll be screening for depression, there'll be screening for suicide, but from what some of the folks are saying, it sounds like the gap's going to be what to do once they screen positive. And like a lot of things in Affordable Care Act, there are going to be shortages generated by health. And I just be interested in your comments.
Can y'all repeat the question?
Yeah, the question, as I heard it, was if we had today universal appropriate screening, let's say we did a PHQ-2, which triggered a 9, which got into the CSSRS, the Columbia Suicide Severity Rating Scale, which is becoming kind of the gold standard nationally right now. If we had that robust approach in place everywhere, what would happen? Would there create shortages? What I think is right now we know there is it's under siege on the one hand and robust on the other. We have a large specialty and commercial behavioral health system out there in the U.S. with about 50% of the staff who feel like, I can sort of figure this out. I've got a master's. I can have engagement and collaboration skills. And the other half, some of whom just, they literally get sick at their stomach when they're talking about this. And many of whom, about 1 in 4 of your teams, have had an individual die by suicide on their caseload. About half of that group has had it happen more than once. And they have the same reactions that all of us have if someone dies in our life by suicide. They go through grief, they blame themselves, they're angry. About a third of them, it's extremely acute. And some of them leave your workforces because they don't know what to do. So you're right, but I think there's a massive workforce. And frankly, what Centerstone and some of the agencies we've been working with have found is that training everyone in even a simple couple-a-day training or one-day training can have some profound effects. Teros going from 10% trained to 80%, it's a different organization than it was before. And what I was shocked by, which I didn't anticipate, is a very large number of people saying, my organization doesn't support me before. And frankly, they put they put this approach forward. They're calling themselves a Zero Suicide in Healthcare Initiative. They've put some protocols in place. They've put some training. It's not a massive amount of work, but their staff, they love them now. They all think their organization supports them. It's like 2% who no longer believe their organization supports them. So I think we can leverage the existing resources in a really profound way that's going to take us a long way toward answering the question you've got in place, and then we'll see what the net gap is at that point.
Okay, we have time.
And using telehealth.
We have time.
And using a lot of telehealth.
Yeah. We're about to come up on a break. We have time for one more comment, and then we'll have lots of time this afternoon to continue this. So.
I want to piggyback on Mary's challenge to be more disruptive. Tom, I'm feeling guilty about Hill Day in January. And here we are on another Hill Day, so I think here's another opportunity for all of us in this room, and maybe let's get the word out to our National Council, brethren and sisters here shortly. My guilt is you and I sat with the congressman for Knowledge Network Hill Day in January, and we were talking about this effort. And we both, I think, should have predicted the response because it was classic. As we sat with this congressman and talked about our effort for zero suicide protocol, the first analogy he gave us was, I hate these initiatives that think we can go from something to nothing, like No Child Left Behind. We should not have national initiatives which we cannot accomplish. We should not be telling the world that no child be left behind when we know we're going to leave kids behind. Now, I love this congressman. I do. I think he's one of the brightest individuals we have in Congress. And that tells me a lot, I think, about the way others are thinking, that are not nearly informed as this individual, not nearly as invested as this individual. And my guilt, Tom, I think, is because we both looked at each other, said to him, we're committed to this effort, but I've not followed up individually with him since then. I've not put either one of these articles in front of him, and I'm thinking maybe the beginning springboard in here is we ought to come up with at least a brief white paper off of these 2 articles that will allow each of us to start engaging in this conversation. At least let's start the conversation as there is some place to go from here. And if our thinking is, equivalent to No Child Left Behind, then we really are in trouble. Then we might as well just choose another initiative, one that we really think we can guarantee some results with, and pick something more easy. But
Wow.
I'm thinking, we're 4 or 5 days again away from revisiting the Hill, and let's, at least with this group, I think at least our minds are there right now. Let's start that conversation. Let's make reference to some of this. And the last piece, David, is when we start talking about our staffs, I think we recognize that again. I mean, I've had my own personal experience. I lost my supervisor early in my clinical training because she had 4 adolescent deaths. 4 adolescent deaths within the first 3 or 4 years that I was working with her. She left community mental health. She went to private practice because her belief was the population that she was going to work with in private practice were not going to be as high risk as the kids that she was dealing with in community behavioral health. So we've actually resurrected our peer support team, and we have a specialty trained team working with our staff who unfortunately, go through the inevitable with our clients, whether it's attempts, whether it's completed suicides, but they're there really as skilled professionals who have gone through these experiences to help our clinicians through these adverse occurrences that occur in their lives as practitioners.